Going live a little earlier than we used to. What's up, guys? This is PT Pintcast, a podcast that saves physical therapists from missing out on amazing insight, remarkable ideas, and motivational stories in the world of physical therapy. Hey, before we get started, I do want to say thank you to our friends at CBDRX for you. A lot of people are finding out about CBD and they're taking it. As a PT, you're not going to be prescribing this. This is not something that you're going to be prescribing. But if your patients are taking this, you want to know how it's going to affect their treatment. So CBDRX for you put together some resources that are great for clinicians, people using this for like reducing stress, wellness, pain relief. So if you're going to have a conversation about it with some of your patients, you want to know more. So check out their website, cbdrx4u.com. It's your CBD store. They got like 500 locations around the country. They're an expert. Some physicians are in charge of it. So you're looking at research. So if you want to be a little more educated as to what's going on in terms of the conversation in CBD, check out their website. Got a great show for you today. We're talking about pain, chronic pain, and how that comes into play in your practice. We got a great guest, international. I don't want to brag, but we're talking to someone from somewhere outside the U.S. Let's do this. Excited to bring in today's guest on the podcast. Make sure you subscribe to the show on iTunes, Spotify, Google Podcasts, Stitcher Radio, wherever you listen to your audio. Make sure you hit that subscribe button. And people get confused. Subscribe doesn't mean you pay anything, just with the podcast. It's a free subscription. But also the socials at PT Pintcast, Instagram, Twitter, and on Facebook. We're talking today with a physiotherapist, consultant, educator, and lecturer who is passionate about treating the complex pain patient and providing a person-centered approach to musculoskeletal care. I like when they say it across the pond. They say musculoskeletal. I don't know why, but when they say it with a cool accent, it makes me smile just a little bit. Let's bring in the studio right now someone I crossed paths with on the Twitter. Laura Rathbone is on the show. Laura, welcome to the program.
Hi, welcome. I mean, hello. Yeah, I was just thinking then about who's welcoming who. Yeah, I'm just nervous. I was thinking then about musculoskeletal. I don't know whether it sounds that fancy when I say it.
Say it again. Hold on. Let me reduce the background noise. Just say it one more time.
Musculoskeletal.
It sounds way more serious. Like when we say physical therapist, like, that's cool. And you guys say physio. And I'm like, well, that's instantly cooler. Laura, welcome to the show. First question is always the hardest. We get the hard questions out of the way first. What are we drinking?
I am definitely drinking a gin and tonic. I'm drinking a Tanqueray gin with, I think, just Royal Clubhouse tonic. So a sort of standard brand of tonic with cucumber. Oh,
I was going to say, I thought you had sliced your own limes, but you're going really, really healthy and you're going cucumber.
Oh, we're fancy. We're going fancy.
We are. I hope we're talking about our sponsors from CBDRX for you, but we're going to be giving away some of these pint glasses. And these, I made myself a vodka soda. I don't want to brag.
Oh.
Little soda streams. Have you seen those things before? You put little syrup in there, and then you make your own club soda. So I'm kind of fancy, and I'm making my own club soda right now. Well, cheers to you. Thanks for coming on the show.
Cheers. So, soda streams. I remember those from the late 90s, early 2000s. They were always this sort of like American gadget that we didn't have, that I wasn't allowed to have.
I just got one of them, so now I feel like I'm inside the club. So,
what's the point of being a grown up if you can't have something that cool like that?
A little fancy. So, Laura, in your intro, we mentioned you're a physiotherapist, consultant, educator, lecturer in the UK, really passionate about treating the complex pain patient. Let's start with that particular patient population. I love when you have people who specialize and niche down in our professions. Why that particular patient population? What about complex pain drew you in and made you want to dedicate a lot of your clinical practice to it?
Oh, gosh, it's funny because you don't get asked that very much. But so, we're physiotherapists. We're largely working with pain anyway. Most of our populations are coming in with an experience of pain, and that's not to do a disservice to the neurophysios or the respiratory physios or our, long-term condition physios. But when you out in your general practice and you're seeing a lot of pain anyway. So I was always just really interested in what is it, this thing that we call pain? Like we talk about it as if we know what it is, but actually, do we don't. So I got really interested in that. And I was always really interested in the sort of principled approach to neuro rehab. So I was probably always really looking at, how does this person understand this movement, and what motor programs are they using, and how is that being affected? And then just gradually started seeing higher caseload of people with pain, which resonated because, my mum had chronic back pain when I was a kid. And, my dad also had, long-term conditions. So it was a population that I felt tremendous empathy for and could understand, and, felt like it was something that I wanted to dedicate my career to, because, I was that little girl sat at home whose mummy couldn't go to the park. And that's important that we know that. So I suppose I just felt like it was a really meaningful and, satisfying place for me to work. And I felt like I was doing my job as a healthcare clinician. That's what we signed up for, to support people.
Something behind that. I didn't know that about your mom, and that makes a lot of sense, I guess, in one way or another. And no one says that needs to be the only reason that you're drawn to a specific patient population, but there's typically a reason. And I ask people sometimes, like, what about this? What about this drew you in? And I could ask 100 different physios the same thing. I'll get 100 different answers, but to them, it's really, really important. You try to solve questions as well. You have, there's a podcast on your website and laurarathbone.com. This one's a little bit different because you're bringing in philosophy with physios. I bring in alcohol, and then you one up me with philosophy. Talk about why you thought those conversations would be. I mean, first of all, they're philosophers, so those women and men can converse for days upon end about anything. But what happens when you start mixing philosophy with our profession?
Well, so I guess it all stems from feeling like I just want to know more about what pain is, and that sort of drives you to look to people who say they know what it is. So you go to the people who are doing the research, and you're looking for physios and clinicians and mentors. And I was very lucky that one of my mentors, who's Professor Mick Thacker, introduced me to philosophy in my master's. And I didn't really understand what it was, and I sort of went along with the conversations, and I was listening. I'd already been reading some books and trying to understand things like, what is the self from a mindfulness perspective, and from a sort of acceptance and commitment therapy perspective, and what is suffering, and can we move through that, or is that what we're trying to do as physios? Are we trying to treat suffering, and these kind of questions? And then I guess he had a big influence in the fact that he was interested in predictive processing and embodied cognition and phenomenology. And, you start going down the rabbit hole, and you think, oh, actually, this is actually more than just knowledge. This is starting to liberate my sort of truth that I've been given as a physio, that pain is a biomedically dominant or has a monocausal perspective. It's this tissue, or it's this joint, or it's that nerve. And then you start looking at the world of philosophy and philosophy of mind, and how they're interweaving neuroscience and the limitations of our neuroscience, and it starts to free up your thinking, and you become more flexible. And I guess I just wanted to share that with the world. And this is some of the work that is coming out of the collaborations between philosophers and clinicians and neuroscientists and cognitive sciences is really, it's so interesting and so exciting, and it really challenges what you think it means to be human. And that's what we're working with as clinicians. We're working with humans who have a truth about the world and a truth about themselves, and who are trying to gather more knowledge and to update their truth so that they can keep thriving. And I think the more we engage in the people who do that for a living, like understanding truth and trying to figure out, what is this thing called a mind, and what is this thing called consciousness, and how does that change what we think about people, the more probably the more compassionate and the more flexible we become in our approach, which allows us to, move with the person in front of us more fluidly.
Yeah. Well, you're talking about person, you're giving me a different aspect to think about when you say person-centered care, right? Well, obviously there's a person in front of us, right? And I think one of the big themes on Twitter in the last 6 months amongst physios is this, biopsychosocial model. But when you're saying like person-centered care, when you ask a philosopher to talk about that, you're getting a different view. Like it's not very literal. It is quite it's quite figurative, and they start to get into, well, who is this person, and what are their internal drivers? So just some interesting conversations. What have you taken from podcast episodes with philosophers talking about things as specific as pain, but also as abstract as their belief structure and who their self is?
Yeah, I guess one of the things that we want to do, and it's something that I have started to almost like be part of some bigger conversations and bigger work that's coming out, not by me. I'm not anywhere near qualified to be doing that work, but seeing people like Prof. Mick Thacker talking to another friend of mine, philosopher Julian Kiverstein, who's an embodied cognition phenomenologist philosopher, and their new paper that's come out with philosopher Michael Kirchhoff, which is thinking about embodied cognition and predictive processing and pain, and how this might be showing up in the thing that you get from those kind of pieces of work is we don't actually have a philosophy of a philosophy of pain.
Right.
As physiotherapists, how much are we engaging with these ideas? How much are we aware of our own assumptions? We use terminology like embodied, but do we really know what that means, or have we just sort of formulated an assumption that we're just using? And why are we using that without knowing what it means? What is the function of that? What's the utility of that? And so there's quite a lot of crossover for me in sort of like things like relational frame theory, which is the psychology theory that underpins acceptance and commitment therapy. So it's a theory of how people make meanings and how actions and behaviors are entailed and sort of intertwined with these this sort of relational meanings that we create about the world around us, how we navigate as a self through that. And that overlaps quite a lot with thinking about how do we make those meanings, how do we understand what we do as clinicians? And I think physiotherapy is in a place at the moment where there's a lot of conflict and there's a lot of like polarization. There's a lot of like you and me and them and us, and those types of physios do that stuff and I do this bit, and there's and I'm part of that, and I hold my hand up and say I am part of that conversation. But maybe philosophy would help us to just soften a little bit and realize that we've still got a lot of building work to do in the foundations of how we underpin what we do as clinicians. And I think that's what I've taken from it, is that we're not as sure as we think we are. We probably shouldn't be as sure as we think we should be. We probably have a lot more questions to ask. And, you look to people like Professor David Nichols and the work he's doing and on, trying to understand what is this thing, physiotherapy, and what is the future of what we do. We've still got a lot of questions to ask about our profession. It's so young, and we're sort of, we've got various levels of autonomy. We've got different cultural identities that are feeding into this global image of physiotherapy or physical therapy. We've still got a lot of questions to ask. I think that's what philosophy really gives us, is that freedom to
forces us to question. Let's not skip over it. Embodied cognition. For the clinician out there who's listening, and I purposely didn't look it up because I was like, I need to be as clueless as the next person who doesn't understand it. How do you describe embodied cognition?
Oh, so describing embodied cognition is a difficult thing to do, especially because I'm not an expert. So I'm not a philosopher working on embodied cognition. I'm just a clinician that really is interested in pain. And this is one of those things that has come up that I think is something that we can gain from as clinicians if we working with pain, if we look at this. So embodied cognition is a way of, recognizing that there's not only like pain or conscious experience is not just sort of, now I say it. So it's a whole person experience. We're looking at the first person experience. Whatever the person says they're having is their experience of themselves and their world is what it is. And this is what I understand embodied cognition to mean. And there's probably lots of people out there who have more knowledge of it, who say, you know what, Laura, that's not how I see it. Fair enough. And there's probably people out there who've never heard it and thought, oh, that's interesting. So it's a way of sort of I suppose joining the dots between what's happening in our physiology and what's happening in our conscious experience from that first person perspective. So I cannot be an expert on what you feel. I cannot make a judgment on what you feel because I'm not feeling it. And so whatever you say you feel is what you're feeling.
I think that you did well there. I mean, I wasn't trying to make you have a quite little definition, but what you understand it as important because it's going to be a big part in how treatment goes with that person and is what they're believing. So how do you bring embodied cognition into your practice if you're working with someone? What's going on in your mind? What is your literal approach? Like how do you question it? How do you get to it? And then what's your figurative approach? What do you do with that information afterwards?
Yeah, so I guess if somebody comes in and they've got pain in a particular body region, maybe in the past I might have thought, well, what muscles are there and what's the position and, what is the relationship between the angle of the body and the flexibility of it and the strength of it and how might that be feeding? And I might then say that is the cause of pain. And now what I might say is I might still look at some of that information, but I'm not necessarily looking at it as this mono cause of pain. I'm thinking, well, what else is going on in this whole person? So it is a kind of more mature way or evolved way of saying the biopsychosocial model, right? Because we're looking at a human being who has a lifetime of experience. They don't just appear in your room with no prior knowledge, right? They've got a lifetime of experiences and memories and habits and rules and all of these things. And their body has learned how to be their body. So their systems, for example, their endocrine system, their immune system, their nervous system, their respiratory system, that's all learned over time and evolved and got this constant updated model of how to be the very best complex and dynamic system that person is. And so when we see them in clinic, we need to be recognizing that, it's not just, oh, well, this muscle is doing this, therefore that's why you've got pain. It's, well, this body is used to doing these kinds of things, and how does that reflect in the full system and the way that they understand themselves in the world, and what they pay attention to is so much based upon what they have found to be beneficial to pay attention to. So thinking about how have they learnt, how have they evolved as the person that they are to be here and then sat in my clinic, and how can I support this person to thrive beyond me, right, into their life.
You said support and not fix or tell or any of those words. It was support. So how do you do this? Is it as simple as giving someone a prompt to tell you their story and then getting out of the way? Are there different ways to get to this point when you're working with someone?
Yeah, it's such a loaded question, and it's really tempting to give you kind of a very sort of like succinct answer, right? I would love to give you this answer where everyone goes, oh, that's what she's talking about. But the reality is that it does always look different, but you're working from a principled perspective. So a principle of behavior change, principle of compassion, the principle of, flexible, flexible care, understanding and recognizing and respecting autonomy, boundaries. These are the things that I think we need as skills, so that when we go into the session, we don't have this kind of script or the algorithm approach to assessment, where we have to sort of go, okay, and where's all your body parts and on the sin factor, severity, irritability, and nature, and what's your number, right? Okay, and then you move into your next little box and your next box, and then maybe people aren't doing that anymore. Maybe this is a sign that I'm getting old, and that's how I was taught, with a kind of assessment form. but actually we're just able to go in there and have a human to human conversation and say, you know, so what's going on and what do you think about it and what does it feel like and how do you feel and, you know, what's important to you and why are you here for treatment? Because, you know, there's loads of people out there with pain that aren't coming into clinic. You know, you have it. So how often do you go into clinic for pain?
Right.
But so something has triggered that person to attend a clinic with pain. It's not they've got pain and so they've come to see me. It's they've got a pain that they don't understand and that they don't know how to move through on their own. So whatever they've learned in the past they're still at that place where they don't know how to get through it on their own, and they're asking for help. So we want to try and figure out, well, why this pain? Why are you here with this one? And what is it that you're missing because of this, so that we can make sure that we can measure success by your values and what's important to you, rather than, you know, can you do 160 degrees flexion or whatever, you know, these kind of things. I mean, it's I think there is so much of that in our profession, and that's not to say that it's wrong, because, you know, these things have developed because they've been useful. The problem is if we're only doing that and we're always doing that, it's become inflexible, and it's become more about us getting these measures, which I'm not saying are unhelpful or wrong, but are they helpful for that person right there in that moment? Are they meaningful to that? But do they even know why we're asking them to, you know,
right,
hop forwards or do a proprioception star? Yeah, exactly.
And what are you missing by only paying attention to those things?
Yeah, I mean, that's the thing, isn't it? You know, we want, you know, nobody goes into our profession because they want people to be angry when they leave our clinic, or they want people to be unsatisfied. You know, we go into this profession because we want to help people find a way to have this beautiful relationship with their body and self and their environment and their values, you know. But then we go to clinical school, and the focus so often shifts towards biomechanical goals and biomechanical diagnoses, which, you know, there's so much controversy over so much of this stuff now. And if we're not engaging in that conversation, especially as musculoskeletal therapists, then what are we? Are we part of the development of our profession, or are we just, you know, sitting back and getting on with the job? And you know, so I think that's how I feel we should come at this. That, you know, developing your knowledge. Like, so, you know, if you're working with people who present with pain, whatever the timeline of their pain is, the temporality of their pain, like, we're still working with pain. And so we need to understand the science of that pain. We need to be thinking about, you know, where are we in this massive landscape of evidence that spans from, you know, philosophy to all the way through allied health into medical. You know, all the different medical professions are working with pain, right? There's no department in the hospital that isn't trying to understand pain. Nursing, you know, nursing's got some beautiful research out there on empathy and relationships and self-awareness and reflexivity, and, you know, then going all the way up to the humanities, which is also a part of our medical landscape, you know. So, you know, people trying to figure out how to express the unexpressible, like pain, you know, the unshareable experience of pain. How do we create a piece that is so moving that somebody who is having a completely different experience from a completely different background can go, "Whew, wow, that's there. I get that." And that's what humanities brings us. It brings us the human again. And if we're not, that's where we need to be looking at this in pain. And I'm so grateful for the teachers that I've had over my life that have sat me down and said that to me, and giving me the skills and the motivation and the interest to look across that landscape. Because it has, I mean, I don't think I would still be a physio if I hadn't done that. I think I would have probably felt really frustrated and like I wasn't good enough. There's something wrong with me. I just don't know how to do this thing, that everybody else seems to be able to do. And yeah, I think that's, yeah. So I probably haven't answered your question really. I've just rattled on about what I like.
Where we talk physio with alcohol. So, you know, I think you said a lot there. And one of those things that you touched on, I wanted to go next, which is multidisciplinary team. You know, you talked about having a podcast where physios meet philosophy. You brought up, nursing and other allied health professions that come into it. Talk to me about the different members of the neighborhood in terms of other healthcare providers and how they come into the play, in your practice or in what you've seen.
Yeah, so I mean, at the moment, I work as a single discipline. It's just me in my practice, but that doesn't mean that I don't function as part of a multidisciplinary. So each patient has their own medical team. Each patient, so you reach out to their team and say, this is what I'm doing over here, and you want to know what the psychologist is doing and the GP is doing and the rheumatologist is doing and the pain specialist, because this person is sat trying to navigate all of that and trying to figure out, how do I get through this difficulty using the best of all of these different people. They just want the best out of us because they need it. And so I would say that, and I get that this is really difficult for people who are seeing like 14 patients a day. You can't be, the system works against us here. Right. So I'm not in any way saying that every single physio needs to go out and start communicating with all of the healthcare professionals that are involved. But, maybe we could start taking more steps towards including other allied health professionals. So, if somebody is having some treatment with a psychologist, maybe we could reach out to that psychologist and just say, hey, I'm over here. I want to support your work as best I can, so that we can give this person the best experience of healthcare we can give them. But, even more basic than that, how I get to spend a lot of time with undergraduate clinicians and early career clinicians, which is like, I just love working with early career clinicians, physios or MSK therapists. But one of the things they say is that often is that they feel nervous about asking people about their feelings because they don't want to be like a psychologist. And I'm like, well, do you know, have you been to a psychologist's office and watched what they do? Just basic stuff like observation outside of your own professional sort of lane could go a huge way to, having your own map of what the multidisciplinary team means, because we need each other. And, we can learn so much from each other, like, communication strategies. It's no surprise at all that the biggest educators in communication strategies and therapeutic alliance and compassion are psychologists, because that's their specialist job. So, if you've got a psychologist around the corner, you've got somebody who's probably really willing to share, and you can cross-pollinate as well, because we have a lot to teach psychologists too. And we've got a lot to teach each other about our profession, and we can support each other. And, we're stronger together.
I love it. I remember the light bulb moment for me. Like, my background obviously was like a radio broadcaster, so I thought I had nothing to add to my PT curriculum and my classmates. And when we got to the subjective examination portion in orthopedics, I remember, our professor was like, okay, who wants to come up and just, the professor was going to be the mock patient, just ask me a bunch of questions. And I watched, my classmates who were all way smarter than me. I'm way younger, just come out of like their undergraduate degrees in biology and kinesiology. And they kind of were like, I don't know, where's the sheet? Where do I follow? And I was like, oh, I used to go into interviews and like have like 2 notes that were hand scribbled on my palm and go, hit these 2 topics. How? I don't know. Just hit them, figure it out, talk about the person, get them going first. So to see that, you're talking about psychologists and understanding how to get someone talking, because that's when they're going to reveal some things that maybe they didn't put down on their intake form, that maybe they didn't know where it went or think it was applicable. And it's the light bulb moment that makes it go on. So I think those soft skills, as they call them, which I think is a giant misnomer.
No, we have to stop that. We do not use that anymore, because, like allowing somebody to be vulnerable in front of you. And again, this just comes down to the sort of the patriarchal, like this kind of paternal idea. If it's soft, it's somehow not as good as if it's hard. Right. Stuff that's hard is like masculine, brah, and like stuff that's soft is like, that's the carers. And, that bullshit. Oh, sorry, I'm probably not allowed to swear.
Oh, it's okay.
But like, and I'm not normally careful, but I like
it that we're getting somewhere.
But like, allowing somebody else to be vulnerable in front of you. So being able to hold a safe enough space for somebody to say, this is really hard and I don't know how to do it, and there's all this other hard stuff happening and I'm struggling, is really, really scary, and can be really scary. And, it's a really brave and difficult thing to do. So it's not a soft skill. It's a necessary therapeutic skill that we have a responsibility as clinicians to develop, just as much as biomechanical assessment and, massage, whatever it is that you invest in the most of the time. If you have never been on a communication course as a clinician, you have not upheld your end of the bargain.
Right. I like that. I like that a lot. I mean, it's a rapport building. It's a relationship building skill. I studied, again, my undergraduate degree was in journalism and communications. We learned about
Mine
public.
too.
Was it really?
Yeah.
Really? I didn't know that. That's cool. So I learned communications and public relations from a Franciscan friar. That was my professor. Case degrees, also death to the term soft skills. I love that. So Franciscan friar standing up in front of my class of freshmen, journalism students, and he says, define public relations. And a bunch of kids were trying to be hot shots and raising their hand and giving these like long-winded definitions of PR, spin, damage control, blah, blah, blah. And of course, he's a Franciscan friar, super reserved, always the basics. I'm like, I'm not falling for this one. And he stopped and he said, I remember the way he looked, and he quieted the room and he just went, public relations is building a relationship with the public. Yeah. The answer's in the question. Now, this term that we're never going to use again, but maybe Chase was saying death to soft skills, that you can do public relations, you can build a relationship one-on-one. That's a super important skill. And the only way you do that is it can't be one way. It can't be, I'm smart and this is what you need to do. That's the quickest way to shut someone down in advertising or in relationship building with one single individual human in front of you. It's got to be two-way. And I'll tell you this, if it's this way first, if you're allowing them to communicate first, it's going to go way better. So getting them going.
Yeah. I mean, I think, we have a shared undergraduate. My first degree was in journalism, and I worked a lot in radio. That was my preferred medium, hence the podcast probably. And PR, I worked a lot in PR as well, consumer facing PR. And it, like, as much as like I look back on that time and I think it taught me a lot, it taught me a huge amount, but it also was a hard slog because it wasn't in line with my values and my ethics, and I found that really difficult. But building a relationship with someone, if you can't build a relationship with someone if you're telling them what to do. That's not how it works. And marketing, PR, advertising, they are some of the most advanced areas of industry that are understanding cognitive and behavioral science and communication science. Now, that's much to our detriment, right? Because we fall for it quite a lot. Right. But if we're working in healthcare and we are a rehabilitation part of healthcare, right? So we're not surgeons and we're not A&E, emergency responders. We're out in therapy. And the whole point of what we do is taking people from, something has happened like sickness, illness, injury, and we're going to bring them closer to their life. We're going to slowly sort of phase them across back into whatever it is that they were doing before this thing happened. So we need behavior. That requires an understanding of behavior change. Now, whether we understand behavior change is another question, probably for a much bigger drink. But, having an understanding and being part of the conversation doesn't mean that you know the answers. It means that you're thinking flexibly and, progressively and trying to reach something. You're trying to improve and be part of the evolution of that. So we're not there with behavior science. When I say we, like, who the fuck am I? I'm not there. I'm not doing it. I'm not the research. Those amazing people that are doing this research, they're still not sure. So we probably need to be going with them on that journey because we're going to need that science, and we do need that science. And I would say that we don't get enough of that, and I think that's a shame because we don't realize that our super skill is actually being able to talk to somebody and being able to connect and being able to say, that thing you want to do, great, we're going to get you there. It might not be perfect and it might not look the way you want it to look, and it might not look the way it looked before this thing happened. But if you want to do that, we're going to do our best to get you there, and probably will if we can keep that in mind.
someone will take that message and go, all right, I'll follow that. Instead of you saying, I've got this thing I'm going to do to you and I'm the expert and you just sit there and I'll do there's no relationship built there when you tell someone what to do.
No.
About courses, I wanted to make sure you got to share the courses that the courses and coaching that you get to do. Talked about that again. That website is laurarathbone.com.
Yeah, so I guess first of all, like the first people I want to talk about are the Pub Scientifique, which is our shared interest of a good old fashioned drink and a little bit of science.
The Scientifique, what was that a year ago, and then what is that before COVID, we'll call it, and then what is it now, and what's the goal? What's the reason you do this?
Yeah, so Le Pub Scientifique started back in 2011 with Tim Beams and Steph Polton and a couple of their other friends. They were in collaboration with like Mick Thacker and another physio as well called Danny. And they sort of had this idea, and then Tim and Steph really, really developed this forward and really put so much beautiful energy into it. And it was a place for like-minded physiotherapists to meet up in a bar and chat about clinical practice and new ideas in science and new ideas in philosophy. And I used to go when I lived in London. I used to go to their events, and that's how I got to meet them. And they're just lovely people that are really dedicated to pain care and our profession, really, as well as the allied health professions. So it would be like, once a month we'd meet in a bar, and they'd invite a speaker. Everybody would have a few drinks, and you would sort of get to network and communicate and talk to people that you might not normally be able to talk to in your clinic, because you might feel like you're in a clinic that's very biomedically dogmatic and hasn't quite taken that paradigm shift, and so you might feel a bit alone. So it was a way to feel less alone. For me anyway, that's what it was. And so then I moved out to Amsterdam and took it with me with their permission to and started collaborating with a friend of mine called Bart van Buchem, who's a physiotherapist and a pain physiotherapist as well. And we started doing these little live events, and it's 15, 20 people in a bar, just having fun with a researcher, really, and getting to actually meet them and talk to them and have the sort of bar side chat, which was just where all the best ideas come from.
I mean, we've said it before, the tagline for the show is the best conversations happen at happy hour. Welcome to ours. It's when it's the conversation after the conversation. It really is. If you go to a big scientific conference, the person on stage delivers a great talk or whatever, and then they say, are there any questions? Some people raise their hand, most people don't. They say, okay, thanks. Everybody claps, and then people rush the stage to that questions. It was like, where were you? But that is really where the magic happens. It's hard to facilitate that, like to bottle it, but it sounds like Le Pub Scientifique does that. It kind of says, all right, what are we here for? We're here to talk and learn and interact. Great, let's do that.
Yeah, and then then COVID hit, and so we had to rethink what we were doing, and we sort of came to a decision as a team. So we were sort of two different groups, and not two different groups. We were the same team, but we were in two different places. And so we decided to collaborate more closely and bring the Pub Scientifique to what we call homebrew, which is you're in your home bar now, but you've still got this relationship with the researcher, and it's almost like, I mean, we love having our speak. We've got Dr. Kirsty Bannister next week, who's a neuroscientist out of King's College, looking at supraspinal mechanisms of inhibition and conditioned pain modulation. Is that something that we can understand? And these kind of things is just getting to talk to those people and ask them about their ideas and motivations and inspirations and directions and what do they think we should be doing. You just don't get that at a conference, and nor can most clinicians even afford it, right? So not everybody's got funding to go to a great conference that's like $2,000 and in a different part of the world, and so it's just an opportunity to bring like the people who are really at the forefront of discovering new targets for pain care, new understanding, modeling approaches that will help us on the shop floor. If we take the help, if we invest and put the time in to learning and evolving with the science, it will help us.
You had me at the pub, to be honest.
Yeah. And it's nice to be so informal. So that's one thing that I do. And the Pub Scientifique is just, it's a lovely team to be part of, and we're all clinicians. The thing that drives us is, what is pain? How do I understand it more? How do I help people more? And so which researcher, which scientist, which philosopher is doing that at the moment. And so that's great to be a part of, and I'm really dead enthusiastic about it. But I also do a few other things. So sometimes I lecture in universities, which I like to do. And sometimes I work with multidisciplinary teams and monodisciplinary teams that sort of recognizing they need a sort of knowledge shift and a skill shift. And they want to find out how to do that. So I go in and observe and try to sort of talk to a few people on the ground and do a round table and figure out, well, what is it that you as a team need? Because, pain, we do this thing in pain, don't we, where we say, it's all about person-centered care and flexible and all that. And then we teach it as a curriculum to everybody, and everybody gets the same thing. But, different teams have different missions, visions, different ideas. They've got different knowledge bases, different groups, and they're working with different patients who have, as a whole, there are themes into what they need and what they want. So it's nice to be able to do that in a close way and be part of those conversations. So that's something else that I enjoy. But in terms of course offerings, so I also teach, so it's called ACT in the Clinic. It's a kind of, we use acceptance and commitment therapy as a model and a framework to develop our skills as clinicians in behavior change and understanding people and understanding ourselves. And, ACT is not a treatment for pain, right? So if you go out and you learn, acceptance and commitment therapy or the hexaflex, or you go and learn the metaphors and you learn a few exercises, great, but it's not necessarily a treatment for pain. But what it is it's a framework that is robust and flexible, which means that there's lots of options and there's lots of different ways of doing it. And it can help us, on a personal level, recognize when we're getting distressed, when we're getting overworked, and manage our work-based stress, of which there is lots in physiotherapy. Yeah. And also, support and recognize when somebody else is dealing with those things, and, find ways to, help somebody observe that in themselves so that they can start to come up with, solutions and actions and steps that make sense to them. And so it's a 4-week course that's completely process and dialogue based. So there's no curriculum. So there's a kind of, these are the things I want us to explore. And then we meet each other on the first day and get to know each other and find out your experiences and what you're interested in. We talk about relational frame theory, the underpinning psychology theory, a bit about pragmatism and functional contextualism, which are the philosophies that are associated with that, and about, phenomenology and embodied cognition, trying to bring up this flexibility in how we see what it is, humans and what it is to be human. And then, we start making agreements about what we're gonna cover over the next few weeks, and we put it together. And that's what ACT in the Clinic is.
Okay. Find out more at laurarathbone.com. Laura, you ready to do 3 questions?
Oh, yeah, sure.
Yeah. Take a sip. We'll do 3 questions. All right, 3 questions brought to you by our friends from Fusion Medical Staffing. If you're a physical therapist, if you're a physio, you want to do what you want to do, where you want to do it. So 3 questions from fusionmedstaff.com, #TravelPT. You want to live at the beach and be a physio? You can do that. You want to live in the mountains? Why can't you do that? You can. You can completely do that. Wherever there are people, that's where they need physio. So first question, Laura. I know you visited New York a couple of years ago, but if you could go anywhere in the 50 U.S. states, where's somewhere you wouldn't mind taking a short trip once everything is safe?
So I would like to visit San Francisco at some point. I have never been there, and I heard the coffee is pretty good and the vibe is pretty cool. So I would like to go and see San Francisco. Yeah,
you got to go to Haight Ashbury in San Francisco. It's great. And where there are people, and like in San Francisco, there are the need for physio. So again, fusionmedstaff.com. Our second question is a what question. What is something you've watched, read, or listened to? A book, a movie, a podcast, physio or non-physio, it doesn't matter, that you think the audience would get value from?
Oh, I mean, without a doubt, like I recommend. So the book Aches and Pains by Louis Gifford is a game changer in terms of physiotherapy and opening your eyes up to different approaches. It's not the truth, but it's something that a very, very wonderful clinician wrote, who had huge knowledge and can help our profession profoundly. Unfortunately, he's not with us anymore. But Louis Gifford's Aches and Pains.
Love it.
Go and read it.
A few times before for people on 3 questions. And the final question is a who question. Who is someone the audience should know more about?
Who is somebody the audience should know more about? So in terms of our role and our profession, I think you should definitely be always looking to the pain ambassadors. So people like Gilletta Belton, Keith Meldrum, Kat Glaw, Louise Treverne in the UK, and, really thinking about, the people who have a lived experience of pain, who can give us so much wonderful and useful information and help us to do our job better with the people that we work with. So, yeah.
Well said. That's 3 questions. You're off the hot seat. You can take a breath. From our friends at physiostaff.com. Laura, the last thing we do is the parting shot. You ready for the parting shot?
Okay.
Do that. Parting shot brought to you by our friends from the Academy of Orthopedic Physical Therapy. Find them online at orthopt.org. If you're looking to level up your orthopedic game, a lot of ISCs, that's fancy talk for independent study courses. I know the specialty examinations were just happening this last week across the U.S. If you're ever thinking about, if you're toying with the idea of that OCS, current concepts of orthopedic physical therapy, that's a roadmap. Right? Go from wherever you are in your PT career. You want to be more confident, more competent. Current concepts of orthopedic PT is the way to get there. orthopt.org. It is made by the Academy of Orthopedic Physical Therapy. All right, parting shot, Laura. No pressure, but this is your chance for like a mic drop moment. What's the thing, the sentiment, the idea, the phrase, whatever, that you'd want to leave with the audience as we wrap up today?
Oh, always believe the person in front of you. Without a doubt. The person in pain, always believe.
Well said.
Yeah.
Yeah, well said. Website again is laurarathbone.com. You can find and connect with her there. Laura, appreciate you coming on here and mixing it. I think biopsychosocial has said a lot, but you're mixing, and listen to that podcast as well as Laura's website. You're mixing in this philosophy, because when we're talking about a person, then the philosophers will say, well, what is a person, right? Those philosophers, always annoying because they always keep asking us more questions. You ask them a question, they ask you 2 questions back, but the goal is to get a deeper understanding. So you're doing that, mixing physio with philosophy at that website as well. So thank you.
And just to say, I'm not the only physio doing that. Please, there are other physiotherapists doing this, especially just a shout out to Matt Lowe, who is a physiotherapist in the UK, who teaches me a lot all the time. He's brilliant physio. Please listen to him as well.
Excellent. And then also follow Le Pub Scientifique on Twitter and just kind of jump in on that conversation as well. Laura, Rathbone, appreciate you stopping by. Thank you for that.
Yeah, thank you.